بيكم كلكم في الجلسة الصباحية. ميت ذا بروفيسور. طبعا بيسعدني دايما انه اخي العزيز دكتور علاء الجندي اللي هو من الطيور المهاجرة وسافرنا في امريكا، و one of the major pillars في جمعية الشعب المصرية. برحب بيك يا دكتور علاء. ودكتور علاء هو بورد سيرتيفايد بالمونولوجيست وكريتيكال كير سليب ميديسن كونسلتنت ودايركتور اوف لي هاي بالمونري اسوشيتس ان لي هاي فلوريدا يو اس اي. برحب بيك مرة أخرى يا علاء، وهتدينا النهاردة اللي هي البالمونولوجي سيشن، البرونكولوجي سيشن اللي هي انترفنشنال بروسيجرز في البراكتس بتاعنا. اتفضل يا علاء. معلش ام سوري، هو الظاهر الناس يعني بتصحى براحتها بقى النهارده يوم الخميس.
معلش هو صوتي طبيعي عادي، بس من امبارح بالليل النهارده الصبح يعني اعتذرت يعني ارجو ان الصوت هيبقى واضح ان شاء الله. يعني الدكتور طارق دايما كرم وعطف كبير كل الناس. يعني انا بشكر حضرتك على الدعوه الكريمه، ودايما مع بعض في الخير ان شاء الله. وبشكر الحضور اللي موجود اللي تعبوا نفسيهم وصحوا في الفجر عشان يحضروا المحاضره. انا همشي في بوينتس عشان نخلي الاجنده on the schedule. Today I'm going to cover lung cancer screening and the screening updates. I'm going to talk about the navigational bronchoscopy, and I'm going to talk about the pleurix catheter and the endobronchial ultrasound. Can you hear me well? Okay. The other thing that I'm going to talk about is the new updates in the asthma management and the role of the valves in COPD and emphysema patients. The procedures that a pulmonologist can do, usually we started all with flexible bronchoscopy, and thoracentesis are the bread and butter of pulmonary. The therapeutic kind of evolved over the years. Now the interventional pulmonologists do a lot more than what it used to be. Not even 20 years ago, it's only about 10 years ago. We do the bronchoscopy, the magnetic navigation, the endobronchial ultrasound to diagnose and stage lung cancer, and percutaneous ultrasound guided biopsy, rigid bronchoscopies, a lot of other procedures, and the tunneled catheter that made a difference in the patient's quality of life with malignant pleural effusion. It's sad to say that lung cancer is still by far is more than any of several combined the deaths due to lung cancer. So lung cancer death is still not controlled. There have been some trials of what can we do to improve that. And in order to improve that, we need to screen the patients. There have been multiple screening proposals, x-rays, sputum, narrowband lighting, but finally, over the last 2 years, there was a trial that started to look at the high-risk patient who are between 55 and 74 who smoked more than 30 packs per year, and if they stopped smoking, it has to be less than 15 years. The good thing about this trial, it ended up earlier because they reached the goal that they were looking for. By diagnosing lung cancer early or finding the nodule early, there was a 20% improvement in mortality. That's a significant number. The number needed to treat 320 patients. So for every 320 patients that we screened, we were able to pick up a lung cancer early. That's a very similar number to the screening for mammography in the older age, not in the young age, but in the older age. And that made a significant impact on what we do. It led to an increase in the diagnosis, increase in the nodule detection, and what happens is the majority of the nodules that we're finding, they really don't need an intervention. Only about 5% of the nodules need intervention. Once a nodule is picked up, like this nodule here, what to do with it? I have to risk stratify this patient is this patient in a low-risk group or in the high-risk group? If they are in the low-risk group, we all follow the Fleischner Society guidelines, which is following the nodule over 2 years to demonstrate radiographic stability. If it does not increase in size, then probably we'll just forget about it and not do anything. But for the 5% of these patients, these are the ones that we need to look for. And for me to be able to reach these nodules, there has been new tools on the market. One of them is a navigational bronchoscopy. Navigational bronchoscopy basically is an electromagnetic field that the patient sleeps in. And it's kind of like a GPS. It guides me, but without talking. I know where the lesion is, and I can go through it. This is one of the systems. There are 2 systems in the market. One is a Super D, and the other one that's new in the market is called Viren. When I say no, it has started since 2007, but it finally made a different impaction. They offer a better platform, and they offer what they call the skin perk. When I do my bronchoscopy, if I can't get my answer from the bronchoscopy, I go percutaneous with the needle, because the needle will guide me. All their tools have the tracking device at the tip. So that's a major difference between Viren and Super Dimension. Viren, all the time, you know where you're getting to. With the Super D, you get there, but once you get there, you move the location guide, and then you go with the forceps. So your forceps is being done kind of blindly, but you always confirm your position. I have this video simulation here where the target is here. It monitors the inspiratory and expiratory variation. There is about 3 centimeters difference in the nodule placement between inspiration and expiration. There is this tracking line that I'm following as I'm advancing, and it's taking me into the lesion. After I'm there, I use the peripheral probe to confirm my position with the ultrasound. I use the Olympus ultrasound to do that. Once we make the diagnosis, there are different options, and one of the palliative treatments, unfortunately, I finished talking about the lung nodules and detecting it early. Now, what are we gonna do when we have an endobronchial mass? This endobronchial mass, I'm only going to talk on selected procedures. For now, I find the lesion, I dilate around it, and I use the Endotech, which is basically a stent that I can place with a fiber optic. This is not one of the rubber stents or the other types of stents. There is a line, I pull on the line from the top, and then the stent starts opening up, and once the stent is there, I verify my placement with the scope, and if it's in the right place, I leave it. If it's not in the right place, I can pull it back. I'm not going to talk about the common complications of the stents, because it's generally the stents can migrate, it can occlude, but it does a role. With the endobronchial ultrasound, the combination of the endobronchial ultrasound from the bronchoscopy and from the EUS, from the GI colleague, there are cases that the GI and we work on them together to get to the lymph node to be able to better stage these patients. And this is the peripheral probe where I push it all the way to the lesion, and then I confirm my placement. Another representation, how the needle comes out. And that's an animation that was made by Olympus, that basically you're in the airway, this is your ultrasound. The interesting about the ultrasound is that the camera is not at the tip, similar to what we used with the regular scope. It's here. So for me to be able to drive the scope, I have to be looking at the ceiling. I have to be looking up. Because if I'm driving the scope the usual way, the ultrasound probe will be hitting on the vocal cords, and I will not be able to pass it. So there is a little technique to pass in difference in passing the ultrasound compared to the regular scope. Once I identify the nodule, I make my measurements, and then as you can see, the needle is passing through. So I'm always seeing the needle where it's going. I'm far away from the vessel. That's the advantage the ultrasound offers over the regular TBNA. If we have a malignant pleural effusion, back in the old days, we used to put a large bore catheter and have the patient admitted to the hospital. And once the drainage is less than 100 cc's, we put the pleurodesis agent. With the tunneled catheter, it is easy to put. It's a tunneled catheter. And it has a one-way valve, so there is no chance for air leak. We educate the patient on doing it and draining it at home. Patients can continue draining it according to different protocols. There is either a daily protocol or every other day protocol or sometimes once a week protocol. But the problem with once a week protocol is that the pores are small and the catheter can get clogged. So if I don't have any fluid coming out, I generally get an x-ray and find out, do I still have the effusion or not? If I see the effusion, I try to flush the catheter to make sure that the catheter is patent. We finish cancer and we go to some promising techniques. The bronchial thermoplasty is used to treat severe persistent asthmatics. It is interesting that there is a 4,000 asthma-related death in the US a year. It's 11 patients that die every day from asthma exacerbation in the US. We're all familiar with the guidelines and the stepwise approach where we start the short-acting and where we end up with the different combinations. When we get to this point here in 5 and 6, what we need to do is we have a procedure now that we can use. It's used to deliver a heat application. I'm going to skip a couple of slides. And it's used to use a thermal energy to treat airway walls that are more than 3 millimeters in diameter. By doing this, I'm reducing the airway smooth muscle, hoping to reduce the bronchoconstriction and hoping to reduce the asthma exacerbations and hoping to improve the quality of life. When we take a look here, this is a normal airway with a smooth muscle. This is the asthmatic patient with the smooth muscle. You can see the bulk of the smooth muscle. In this here, that was a canine model that was used in the beginning of the trials where you can see the smooth muscle and then you can see what's left here, these little brown dots of the smooth muscles after using the thermoplasty to treat the airway. As I mentioned earlier, the procedure uses the layer radiofrequency with the 4 electrodes. I'm going to skip to the picture. This is the equipment. This is a box. This is a catheter. This is a paddle that I use to deliver the energy. And this is the ground electrode because the patient has to be grounded. A common mistake that the patient think of that these wings here, I'm using them to expand the airway. I'm not. I'm just using them to touch the airway. So since there is a lot of variability in the asthma airway, there are smaller airway, there is a larger airway, so we need to make sure that there is a contact from the wing here to the airway. In the patient preparation, I usually give the patient 50 milligram 3 days before the procedure, IV salmeterol on the day of the procedure, and then 50 milligrams 2 days after the procedure. We usually pre-treat the patient with a bronchodilator. We check the baseline spirometry before the procedure is done. It's similar to, the anesthesia is similar to any other bronchoscopy. And after the procedure is done, we discharge the patient somewhere between 2 to 4 hours. Once the patient is awake, we recheck the FEV1. And if I'm more than 60 to 80%, it varies. I know my patients very well. I don't do the procedure on patients that I did not meet and I did not thoroughly follow them. The selection criteria is what makes a thermoplasty successful. It's not a procedure for every asthmatic yet. The procedure, as I mentioned earlier, is done in 3 steps. Usually the right lower lobe, the left lower lobe in 3 weeks later, and then in the 3 weeks later, we treat both upper airways. I'm gonna skip this one, and let me see if the video will play itself. This is basically advancing the catheter in the airway and looking at the marks. We usually treat distally and then go proximally. Now, where is the speaker بتاعت اللابتوب فين؟ And that did not show. معلش, we have a technical difficulty with the sound, but once the catheter is in place and I can see my marks, I hit the paddle, and then there is a distinct tone that, can you hear it now? So once I finish, then I pull the catheter back, and then I deliver another activation, and it's another about 10 seconds of the same noise. After a while, after doing the procedure for multiple times, it starts getting boring. At the beginning, it was exciting, but then at the end, you just keep delivering the activation and making sure that you following up the right sequence. The candidates, as I mentioned, are the severe persistent asthmatic, more than 18 years old. It's not FDA approved for kids yet, and I don't think it will ever be approved for the kids. Patients will be maintained on a combination with the difficulty to control their asthma. In this here, what we can see, this bronchial segment was treated before with a thermoplasty. The other segment was not treated. After putting methacholine in the airway, you can see that how the segment that was not treated reacted compared to the segment that was treated. I started doing the procedure about more than 2 years ago in the Southwest Florida, and that was the first patient that I have treated. So far, for the last 2 years, she has not been in the emergency room. She has not been in my office out of the routine visit. She has been well controlled since the procedure has been done. And that's what we kind of hope. We don't give the patient a false hope and say, I'm going to do this procedure and I'm going to take you off your inhalers. It doesn't happen. There's no data so far that show that you can take the patients off their inhalers. The only data that have shown is that you can, or the patient is reducing the number of rescue inhalers. But other than the control medications, all the controlled inhalers are still on board. This is the pilot study where we submitted our work to the ATS, and you can see this is the baseline. So we had patients with FEV1 of 55 to 85% across the board. So we had a different FEV1s. This is here after the first PT, actually this was after the first PT session, this is after the second PT session, and this is after the third PT session, and this is 3 months later. There have been multiple clinical trials. For the sake of time, I'm going to skip them, but the most common trial that's referred to is the RESA trial or the AIR trial. For the COPD patients, we, in Europe, and I'm assuming that's in here in Egypt too, there are some trials to offer the valves for the COPD and the emphysema patients as a way of endoscopic lung volume reduction surgery. In the US, it's only approved for the persistent air leak after pneumonectomy or lobectomy. And I would like to thank you for being here and coming in early and listening to the presentation.
Thank you, Anna, for the very nice and informative presentation. And questions? Question and short answers. Any question? Leila, any question to Ala?
Thank you, Dr. Ala, for this interesting presentation. الحقيقة أنا كنت عايزة أسأل على الثيرموبلاستي. الثيرموبلاستي تكنيك طبعا بغض النظر عن التكلفة والأسعار والكلام ده. ازاي هيحس العيان ان هو اخد فاليو؟ يعني هل انت بتحس البلمونري فانكشن اتحسنت، وهل هي تقعد فتره طويله الافكت بتاعها؟ هل انا محتاجه نعمل ريبيتيشن للسيشنز دي؟ هل ليها اي سايد افكتس او كومبليكيشن هيعاني منها؟ يعني انا وانا ازماتيك هعمل ثيرموبلاستي على حسب اللي انا فاهمه من حضرتك ان انا هعمل 3 سيشنز مثلا. هقعد قد ايه انا بقى؟ هل انا محتاجه تريتمنت معاها ولا خلاص انا بقيت نورمال؟
الثيرموبلاستي زي الليسك بالظبط. It's once in a lifetime. There is no data on repeating it. So when it's done, it's completed unless there is a contraindication that happens. You want to stay away from a patient. You want to do thorough investigations first. So with a thorough investigation, I usually get the IgE, I usually get the ANA. I want to make sure that this patient, if they are on chronic steroids, I'm not doing the procedure to get them off the chronic steroids. I don't tell the patient that, because actually in the initial trial, they excluded the patients who were on chronic steroids. What the company does now is telling physicians.
Chronic steroids, inhaled steroid?
No, oral steroids.
Oral.
Yeah, either 10 milligrams or higher. So these patients were excluded from the trial. So there are some marketing ideas that being implanted and the pulmonologist head in the US that do these patients so you can get them off the steroids. But really, when the AIR trial was done, these patients were excluded from the trial. So we don't have a randomized clinical data on these patients who are on chronic steroids. If I have a patient like this, I tell them that I might not be able to take you off the steroids. The only thing I can say is there is an 80% improvement in quality of life. There is at least 40% improvement in days lost from work or from school. There's at least 60% drop in unplanned visits and roughly around 70% of improvement in ER visits. As far as the management, I want to use an analogy, but I don't want you to misunderstand me. When a cardiologist does a cardiac cath and put a stent Have you ever seen any of the cardiologists take the patients off the medications that they on? They still continue the ACE inhibitor, they still continue the nitro-paste. So this is the same thing. This is an intervention that we have that can be complementary to the medical management. It would not substitute the medical management. And that message has to be clear or clearly sent to the patient. Otherwise, if you do the patient can come back and tell you, but I'm still on my inhalers. You're not doing this procedure to take the patients off inhalers. It's a complementary to what they have. The general consensus that I have from my patients is that they breathe better. There might not be any change in FEV1 or FVC. There has not been any trial that showed a significant improvement. The pilot study that we did showed an improvement in the airway and the airflow in the small airways, and that was not reported in the original trials. But again, my patients' population were a subset that were not studied. They were Hispanic females.
شكرا يا دكتور علاء. هو for the sake of time دكتور علاء قاعد معانا النهارده وبكره ولحد يوم السبت. Any questions you can ask or available. Thank you very much. We proceed with the second session. دكتور إيهاب دكتورة ليلى عاشور.